Dr. Ray here from Vet Triage. We are going through this issue of JAVMA from February 15, 2015. We've got a case study, Pathology in Practice. There you go. This comes out of the vet school in Louisiana. Here's the picture to start off with. There. And the reason for the picture below, you see a dog there. It's got multifocal erosions and ulcerations affecting the nose, the pinna, the periocular region, the gums. I don't know whether it's the same dog in each picture or not, but it doesn't matter. Veterinarians get utterly confused by autoimmune skin diseases because number one, they're usually chronic in nature, and number two, they can show signs that go beyond just skin and mucocutaneous junctions. But I think most importantly, number three, they get confused by autoimmune skin disease because they think they have to diagnose the condition from what they're seeing with the dog. And if there's one thing that you can take away from a case study like this, it's that you aren't going to be able to accurately depict what the diagnosis is just based on looking on the animal. Now, a lot of these conditions do have specific distributions on the body, so you can make an educated guess, and I'm sure dermatologists, maybe pathologists are fairly okay at that, but I'm going to guess that they are wrong a lot too, clinically, until they get the biopsy results back, and then to confirm what they suspect or what the differentials they suspected were. So if you're a veterinarian listening to this or a vet student, you're not going to diagnose. You shouldn't try and diagnose these conditions just based on history and physical exam. These are one of those conditions that you should look at this dog and say, okay, it's probably autoimmune disease. There's a bunch of different possibilities. Let me figure out what testing I need to do to determine what the exact disease process is. This is a 7-year-old female spayed mixed breed dog, 3-week history of licking its feet and extensive ulceration of the paw pads. They found oral inflammation and ulceration on the dog. He's been salivating and painful. And by the way, they say here extreme pain in the report, and they don't specify exactly why they thought the dog was in extreme pain. So that's a problem there. As far as clinical and clinical pathologic findings, focally extensive plaque with multifocal cutaneous erosions on the ventral muzzle and chin. The dorsal aspect of the planum nasale was thickened with hyperkeratosis and ulceration of the planum and philtrum. Multifocal perioral depigmentations and erosions. Gums, hard palate, tongue had multifocal ulcerations. All 4 feet were swollen. I hate that they say feet. They're paws. With ulcerated paw pads and hemopurulent exudates. Minor multifocal perivulvar erosions and the ocular and anal mucocutaneous junctions were spared. They did impression smears of the plaque. So impression smears when you take a microscope slide and you literally push on the lesion to get whatever exudate and cells and debris you can. They found neutrophils and eosinophils with cocci. They did a complete blood count on CBC, and now they say here on the CBC they found hypoproteinemia. So typically, unless there's some special CBC they have, the CBC only looks at cells, white blood cells, platelets, red blood cells. It doesn't look at protein. So I think it's a typo. I think they meant to put that down with the biochemistry panel results. But they found neutrophilia and monocytosis, so that could be, that's a partial stress leukogram at least. Serum biochemical analysis, you found hyperglycemia, which hyperglycemia in this case might be stress related. Hypoalbuminemia, which low protein, they can lose, or low albumin rather, and then low protein from the CBC, which I think is a typo. If you have exudative disease and there's fluids pouring out of the skin and mucocutaneous junctions, then you can lose protein that way, but also the dog could be severely anorexic, malnourished, and it could be also abdominal organ disease like liver. It could be losses from GI tract, from kidneys, a bunch of things there. And it's probably in this case, it's actually an acute phase reaction where the body's trying to fight something and it's allocating all its resources to creating immunoglobulins to fight that disease. And so with that, it's called a negative phase reaction or acute phase reaction. Then the protein levels go down and albumin goes down because they're being siphoned to create more globulins to fight the infection or inflammation. Mildly low blood urea nitrogen and creatinine, those could be spurious, could be lab error, could be unique to the patient. If the dog is severely malnourished or poorly muscled, that could be it as well. Hyponatremia, hypochloremia, hypocalcemia. The calcium was corrected for with the low albumin. So biopsy was collected, and they also did aerobic bacterial culture. They found beta hemolytic streptococcus and a light growth of Pseudomonas aeruginosa and a light growth of Proteus. And it's not surprising you have a polymicrobial infection here because of the extent of disease. Histopathologic examination determined a morphologic diagnosis of severe multifocal to coalescing acantholytic and ulcerative dermatitis, pododermatitis, stomatitis, glossitis with suprabasilar clefting. The case summary is Pemphigus vulgaris in a dog. For those of you who are interested in the histopath, there it is there. So, discussion. Pemphigus vulgaris is one of a group of acantholytic dermatoses that includes Pemphigus vulgaris, Pemphigus foliaceus, and paraneoplastic pemphigus. This group of dermatoses is caused by a breakdown of keratinocyte attachment, which results in the formation of detached keratinocytes, and we call those acantholytic cells. The breakdown in keratinocyte attachment is usually the result of autoantibody-mediated disruption of desmosmal proteins, with each clinical form associated with a differing constellation of targeted proteins. Cutaneous wedge biopsy specimens of intact vesicles or the epithelialized margin of a recently formed erosion or ulcer provide the best diagnostic sample. If you're going to do a punch biopsy, which is not as good as a wedge biopsy, the punch biopsy should be obtained by twisting the punch in a single direction, because back and forth rotation causes shear and artifactual changes. Tissue samples should extend completely through the dermis and into the subcutaneous tissue. Care should be taken to not scrub the biopsy site prior to sample acquisition, but you are allowed to clip the hair. Pemphigus vulgaris is one of the rarest forms of pemphigus in dogs and affects cats rarely. It is distinguished clinically from Pemphigus foliaceus by the involvement of mucous membranes and mucocutaneous junctions. Histopathologically, Pemphigus vulgaris is characterized by the formation of suprabasilar epidermal cells, vesicles, and bullae with ankytholytic cells. Pemphigus vulgaris is caused by binding of circulating autoantibodies, typically IgG4, against desmoglein 3. Patients with lesions on hair skin may also have detectable antibodies against desmoglein 1. Now, paraneoplastic pemphigus is another rare form of pemphigus in dogs associated with cancer. It affects the oral mucosa, mucocutaneous junctions, so differentiating between vulgaris and pemphigus, paraneoplastic pemphigus, is difficult. The desmosmal proteins targeted by the immune system in cases of paraneoplastic pemphigus include envoplakin, periplakin, desmoglein 1, desmoglein 3, bullous pemphigoid antigen 1, and desmoplakin 2. Causes of this dermatoses is associated with a mixture of features consistent with Pemphigus foliaceus, like subcorneal clefting, Pemphigus vulgaris with suprabasilar clefting, and erythema multiforme, which has keratinite apoptosis. Pemphigus foliaceus is the most common form of pemphigus in dogs, cats, and horses, rarely affecting goats. Pemphigus foliaceus causes bilaterally symmetrical crusts and large pustules, primarily the face, pinna, and paw pads in dogs and cats, on the face, neck, trunk, and distal portions of extremities in horses, and the face, ventral abdomen, limbs, perineum, tail in the goats. Pemphigus foliaceus rarely affects oral mucosa. However, mucocutaneous involvement has been reported, albeit uncommonly. Again, you can see there's repetition here, there's overlap between these diseases. Subcorneal pustules that contain rafts of or individualized acantholytic cells. Desmocolin 1, a calcium-dependent cadherin found predominantly in the superficial epidermis, has recently been identified as a major target in Pemphigus foliaceus. Differentials include bullous pemphigoid, mucous membrane pemphigoid, epidermolysis bullosa equistea, erythema multiforme, mycosis fungoides, and fungal dermatitis and stomatitis. Treatment includes immune suppression with glucocorticoids usually, and then adjunctive immunosuppressive drugs like azathioprine, chlorambucil, tetracycline, and niacinamide, cyclosporin, and mycophenolate mofetil. So that's this disease. So yeah, just a nice basic an opportunity to learn about basic skin diseases, especially autoimmune ones, because I think we put a lot of pressure on ourselves to diagnose the condition from history and physical exam. But you can see lots of overlap, lots of ambiguity, and who knows, maybe as time goes on, I mean, this is 2015, so maybe we now see these diseases as a spectrum of one condition with different severities. I don't know. But there's clearly a differentiation between purely autoimmune and neoplastic related. So the other thing they didn't mention here, besides having cancer, could this be considered part of paraneoplastic syndrome? They didn't mention that word with the paraneoplastic pemphigus, but I presume that's probably what they mean by paraneoplastic. So, all right, thanks everybody for supporting the channel. We'll see you tomorrow. Bye bye.